Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. It's quite a complex case. It's an elderly patient who attended with a blocked right ear, and their ear has been blocked for many years. And the reason why they haven't sought treatment previously is because they explained to me that they were and it was very apparent when they attended, they were very anxious. And primarily that's because their mother, many years ago, underwent ear syringing. So there's a difference between ear syringing and ear irrigation. Ear syringing is when you attempt to flush out earwax using an old-fashioned metal syringe. It's a high-powered, pressured metal syringe, which is now banned in the UK. You can't use that. Ear irrigation is when you use an electronic water flushing machine, similar to what dentists or dental hygienists use when you visit the dentist to wash out your mouth after a procedure or during a procedure even. And their mother actually, as a result, developed a perforation of the eardrum due to the high-pressured metal syringe. So this patient's been very reluctant. So in essence, their mother actually went for treatment for their ears but came out worse off. So it was quite a complex procedure for that reason. They also did visit another specialist who struggled, and I can understand why, because another difficulty here is not only because of how old this wax was, but because they had a collapsed canal. Now, normally when you've got a collapsed ear canal, it's on the outer third, the cartilaginous portion. It's normally right near the entrance, so it's the entrance that's collapsed, but it was this patient's midsection of the canal was really narrow. And so even with our smaller size specular, which I am going to use, so currently I'm using our medium size specular, which is a 4.25 millimeter internal diameter, which is the normal one I use for most patients. But I am going to switch to the smaller one. But even with the smaller one, although I was able to enter the ear a bit deeper, there's a limit of how far you can insert a specular. And that's because you don't want the specular to make contact with the bony part of the ear canal, which is probably about a centimetre into the there or thereabouts, because that would be uncomfortable for the patient. So even having a specular, you can only stretch his ear so much, and an endoscope for this reason will be, if you're able to use an endoscope, it's really good, because you can use the endoscope to stretch the cartilaginous portion and kind of somewhat insert it past that narrowing in the midsection of the ear canal where a speculum can't, and then you can insert the instrument in, so you get kind of a better view. Ironically, when we first introduced endoscopic earwax removal in the UK, there was obviously you have the status quo, who used to query it, question it, without having the knowledge around it. I mean, there were some people that says you can't perform earwax removal with an endoscope, which is really quite hideous and ridiculous, because there's ENT surgeons that perform ear surgery with an endoscope. You can see I'm kind of chuckling away, but I suspect that's kind of, that's kind of society in some way. That people are resistant to change, and without understanding the process, the statements made which are inaccurate. So I purposely decided to use the WAXscope because this is where it would be quite a challenge, even if you're using an ENT operating microscope, just to kind of open up the ear and to get a good visual. So now I've reverted, you may have noticed, to the smaller size specular. And we know that because you can see more of the specular. So the smaller the specular diameter, you're going to see more of it on the outside. And that's because the lens is external. Now, I fully appreciate if you're watching this for kind of entertainment, probably not going to be a video that you're going to quite enjoy. But this is a procedure, a medical healthcare procedure. And the reason why I'm highlighting that is because just over the weekend, I've had a couple of emails from members of the public. Actually, it wasn't even in response to WAXscope videos, it's in response to the endoscope videos. And when you read between the lines, it's slightly insulting. I didn't reply. I don't reply anymore. I used to reply quite a lot, and that was purely in the hope of trying to kind of impart some wisdom into some people, because I think it's just not necessary. There's loads of things that I don't particularly like or agree with when I watch things online, but I kind of move on. I don't waste my time, especially wouldn't take time out of my life to email the person and kind of make comments. But unfortunately, I've kind of conceded that that is the way of the world now. I'm not going to be able to change that, not at least single-handedly. And so yeah, um, so I think if you're a professional performing earwax removal, and you'll probably understand more and appreciate more the challenges here, and actually in this respect, the WAXscope, what it is able to do. So we've cleared out the entrance, the midsection, and we're now going to the second half of the ear canal with the wax. You can just see how dark it has been there for a long time. It's a bit matted. I also used the forceps because there was a bit of dead skin there. And with the dead skin, sometimes it can clarinet when you perform microsuction. So I just wanted to remove that skin with the forceps. Even with the WAXscope, even with a narrow ear, even with a small specular, you're able to use all the instruments where they're necessary. So this now is in the latter third. So we've cleared out the outer third, the second third. This is the inner third. And I'm just trying to wriggle this out. We can start seeing the eardrum. And the patient was taken away a little bit because this ear's been blocked for so many years. But the reason why they primarily came now to have it treated is because the wax is beginning to become a bit painful, because it was just building up. This wax is not going to migrate because of how narrow the midsection of the canal is. It's getting trapped. And just trying to loosen it from the right-hand side of the ear canal, bringing it forwards away from the eardrum. So yeah, this patient, I did kind of discuss acclimatization with them. And by that I mean, because this wax has been causing, and there's probably a bit of fungus there, you can see just there to the left. But it's not a pathogenic fungus, so it's just a bit, maybe it's not, maybe it's just, it appears like it was. But just where the suction probe now is, they had a kind of a woolly appearance. Now that could just be the reflections of the wax as well. But yeah, there's no infection once we cleared all this. And sometimes it's not unusual to have a bit of aspergillus fungal strain sitting on the surface of the wax because it feeds off it, but it doesn't really necessarily mean it's pathogenic. So you can see this is the midsection. This is where it's really narrow. We're slowly bringing it through. So yeah, I just discussed this with this patient. They're going to have to acclimatise because the noise, we do live in a noisy world, and in a way this wax has been protecting their ears and they're used to not being able to hear so well. But now we're going to see the eardrum. Got a lovely view there, even though it's narrow. That's the hammer bone. Well, I hope you enjoyed that video, guys. Take care, take well, and speak soon. Bye.